Hi, I'm Chris Fanta. I'm a member of the Pulmonary and Critical Care Division at the Brigham and Women's Hospital, where I direct the Partners Asthma Center, and I'm professor of medicine at Harvard Medical School. And what I wanted to do with this session on pearls and pulmonary medicine is introduce some new topics, review some other topics, and just highlight some interesting aspects of pulmonary disease through a series of 4 cases, if you would. And I don't have any conflicts of interest to share. So what exactly is trying to communicate when we say a medical pearl? I think it's a medical fact that isn't maybe widely known or routinely discussed in medical texts. I hope it's going to be useful information. It's not terribly obscure. It's not meant to be trivia, and God willing, it's true. So here's the first of these 4 cases that I wanted to review. A 52-year-old man who came complaining of fatigue and early morning headaches over the last 4 to 6 weeks. On his serum chemistry profile, you notice that he has an elevated serum bicarbonate, 35 milliequivalents per liter, and he takes no medications, and in particular isn't on a diuretic. He smoked cigarettes since he was a teenager, 1 to 2 packs per day, and has chronic productive cough and sputum production, particularly first thing in the morning. And his examination is notable for relatively shallow respirations, clear lung fields on auscultation. And you notice when he's lying down for exam and you're listening to the heart that he has this paradoxical inward movement of his abdomen on inspiration when he lies supine. So evaluating him further, you obtain pulmonary function tests, and they're abnormal with an obstructive pattern. The FEV1 and FVC are shown there, and the ratio is reduced consistent with moderate airflow obstruction. Arterial oxygen saturation is measured with a pulse oximeter, and it's reduced on the order of 93 to 94% at rest. And curious about this, we obtain arterial blood gases, and consistent with that elevated serum bicarbonate, we find that he has a hypercapnia with a PCO2 of 60. His pH is 7.34, and he has hypoxemia, as was suggested by his pulse oximetry. So for further evaluation, we get a chest x-ray, and it looks pretty clear. It looked like a poor inspiration, the radiologist said. At least they were shallow lung fields. All right, so this is a question about hypercapnia. Why is this patient hypercapnia? The most likely hypercapnic, the most likely explanation is 1, asthma, 2, COPD, 3, pulmonary embolism, 4, respiratory muscle weakness, or 5, kyphoscoliosis. And I think one is tempted to say COPD in this long-term cigarette smoker with obstructive lung disease, but I think the correct answer is likely to be respiratory muscle weakness. And why is that? Here's the pearl that I wanted to share with you. I think it's a useful fact to remember that unless someone is receiving respiratory depressant medications, narcotics or sedatives, or there's some other illness going on, that in COPD, hypercapnia does not develop until the FEV1 falls a good bit lower. His was over 2. Typically, it's less than about 1.5 liters. You have to have severe airflow obstruction in order to cause alveolar hypoventilation and an elevated PCO2 in COPD. And this study done from way long ago monitored a group of patients with COPD, made repetitive measurements of PCO2 and their lung function. And you can see here's elevated PCO2 on the order of what, probably greater than 46, 47 was their upper limits of normal. And all of those patients with elevated PCO2 had an FEV1 less than about 1.5 So I don't think we can blame his hypercapnia on COPD. Yes, he has COPD, but it's not severe enough to explain his hypercapnia. And then there were these other clues that made you think maybe it isn't COPD. He has relatively small lung field, shallow breath on CAT scan, not hyperinflation. And he has this curious paradoxical movement of his abdomen and chest wall when breathing in the supine position. And I think that was a clue towards respiratory muscle weakness, particularly inspiratory muscle weakness or fatigue. It could have been as seen from diaphragm weakness. And I'm not a great drawer here, and so this cartoon is not very sophisticated, but imagine somebody lying on their back, head on this side to the left, feet over here to the right, and on a normal breath in, as we watch someone breathe, chest and abdomen move up on the supine patient pretty much in unison. And then on exhalation, fall back to the initial position as the diaphragm descends like a piston and expands the chest and pushes the abdominal contents forward. So up comes abdomen and chest wall, down on exhalation. And what you noticed in his breathing is that when he took a breath in, he was able to expand his chest with the help of particularly his intercostal and accessory muscles. But there was a paradoxical inward movement of his diaphragm, that there was this uneven motion of chest wall and abdomen, paradoxical inward movement of the abdomen, because the diaphragm weakened or fatigued was pulled upwards, cephalad, towards the head by the expanding chest and negative intrathoracic pressure, and it was weak and floppy and moved paradoxically the wrong way. And so we're thinking in this patient, diaphragm weakness as the etiology in someone with very severe COPD and about to have hypercapnic respiratory failure in the ICU, you can begin to see this pattern of fatiguing diaphragm and intermittent paradoxical movement of the abdomen. In this case, it was a primary respiratory muscle weakness. It does give me a chance to mention other causes of, in this case, a unilateral elevation of the diaphragm. Here, quite striking on the left. Here's this diaphragm bowed up and out of position. And this is the radiographic image, as you know, of a unilateral diaphragm paralysis with the hemidiaphragm displaced cephalad. And if you measured pulmonary function tests in this patient, you'd find typically mild to moderate restriction and a reduction in the vital capacity. Typically, it's more than 50%, but it's reduced more so in obesity plus hemidiaphragm paralysis. And to confirm this, you might, on pulmonary function testing, measure maximum inspiratory pressure. In the pulmonary function lab, they come, they put the mouthpiece in, they're asked to pull in as hard as they can, but the valve is shut, so no air comes in, and so the maneuver, as you know, is pull as hard as you can against this closed shutter, and we'll measure in centimeters of water or millimeters of mercury the maximum inspiratory pressure that you can generate, and his is going to be about 50% of normal. And then confirmation of this suspected unilateral hemidiaphragm paralysis is done with chest fluoroscopy. We're asked to do a sudden rapid inspiration. They refer to it as a sniff test. And during this, the radiologist on fluoroscopy watches the diaphragms. One side that is functioning well will descend normally. The other side that is weak or paralyzed will flop up paradoxically or opposite direction towards the head, sucked up by the negative intrathoracic pressure. So there's this easy to see asymmetry of motion of the two diaphragms on on the sniff test, chest radiology with fluoroscopy. Alternatively, ultrasound can be done. You look at one side, watch the motion of the diaphragm, look at the other side, watch the motion of the diaphragm. I think it's a little technically a little harder, but could give you the same information. And what causes this? You've seen patients present like this, and you wonder, was there some trauma to affect the phrenic nerve? Was there some history of surgery inside the chest that might have nicked the phrenic nerve? Was there spinal nerve injury to this diaphragm, which comes off at C3, 4, 5, as you remember? And we'll probably get a chest CT scan to make sure there's no malignancy compressing the phrenic nerve. But often there isn't. Often we don't find an explanation, and it seems idiopathic. So what are we going to do? We're going to blame it on a virus. We're going to blame it on autoimmune. We don't know. But idiopathic unilateral hemidiaphragm paralysis is common. And treatment, I think, is difficult. Early onset, a thin person, you might think of a surgical procedure to plicate the diaphragm, pull it down to the normal position, but that doesn't improve its function in any way. It just repositions it lower in the chest. In a long-standing patient who's had this for several years or who is obese, the outcomes are poorer for this surgical intervention. And diaphragm pacing, you'd think, would be possible, but although it's done for bilateral diaphragm paralysis due to a cervical spine injury, it's not feasible for unilateral, where you have to be in sync with the normal function. And besides, the problem is the phrenic nerve, and pacing is done via stimulating the phrenic nerve, and in this case, phrenic nerve doesn't transmit normally, so that's not an option. And you wonder whether some sort of respiratory muscle trainer might help. I don't know of any evidence, but sometimes one's tempted to give the patient a device that asks them to breathe through a resistor that's adjustable to increase the strength of their other inspiratory muscles in a compensatory way. I can't share evidence that this is an effective intervention. I have one other example of elevated hemidiaphragm here on the right compared to the left, but this isn't paralyzed. It's harder to see on the lateral that you could distinguish the two diaphragms, but it has a distinctive shape that I wanted to point out. It's elevated. It's relatively flat and then drops off laterally. People have referred to the hockey stick appearance of this. And maybe on the lateral, there's a suggestion of some blunting of the costophrenic angle. And I think in expanding our differential, there's another maybe pearl of the elevated hemidiaphragm. Is it possible that there's a pleural effusion, that below the right lung, that the diaphragm is in its normal position and functioning normally, but a pleural effusion is trapped underneath the lung in a position, in a shape that allows the lung to maintain relatively normal shape, and might fool you to not be aware that there's a pleural effusion. You don't see the obvious meniscus. But if we did a lateral decubitus, now we'd probably do a CAT scan. But in the old days, we'd do a lateral decubitus. In this patient, you can see this fluid on the right side down, tracking up here. Here are the ribs. Here's the layer of layering effusion coming out from under the lung that was sitting above the diaphragm, a subpulmonic effusion mimicking an elevated hemidiaphragm. Good. All right, here's another case, a 52-year-old woman who's come back to you after referral to a hematologist for further evaluation of hypoxemia. So she had presented with a consistently elevated hematocrit on the order of 52 to 55%, but the hematologist astutely identified hypoxemia with an O2 sat of 86% and very politely suggests to you that maybe this isn't polycythemia vera, but it might be a secondary erythrocytosis due to her hypoxemia. Now, the patient is a lifelong non-smoker, although both of her parents and now her husband all smoke cigarettes, so she has a lot of secondhand cigarette smoke exposure. There's no history of hypertension or diabetes or hyperlipidemia or known coronary artery disease. And on examination, she is obese. Her body mass index is 42. And you notice there is some jugular venous distension. She has a clear chest, a prominent second heart sound, and she does have pitting edema to the mid-calf bilaterally. So maybe some signs of right heart failure. Chest x-ray is normal. And sure enough, with your oximeter, her oxygen saturation is 86%, which is not terribly tachypnic or dyspneic. And you ask her, I want you, as you're sitting there with the pulse oximeter on her finger, you say, I'd like you to take 10 big, deep breaths. Let's do it together. In, out. There you go. Come on. 9 more. In, out. And as you do this, and as she takes these voluntary deep breaths, you watch the O2 sat meter, and it rises to 98%. All right. So what do you think is going on here? What's the cause of her hypoxemia and cor pulmonale? Does she have COPD that's due to secondhand smoke exposure? Does she have respiratory muscle weakness, such as might be due to evolving amyotrophic lateral sclerosis? Does she have an ischemic cardiomyopathy, recurrent pulmonary thromboemboli, or obesity hypoventilation syndrome? And I'm hoping you're thinking obesity hypoventilation syndrome, as I am. And why is that? And I think what was particularly helpful was this voluntary hyperventilation maneuver that I wanted to share to you as a pulmonary pearl, noting that if you have someone who's hypoxemic, but by taking big, deep breaths can increase their oxygen saturation back to normal. That suggests that the cause of the hypoxemia was hypercapnia that could be corrected by increased alveolar ventilation, big, deep breaths. And this would be hypercapnia with a preserved AA gradient for oxygen, alveolar to arterial gradient for oxygen, such as is seen in central alveolar hypoventilation. I wouldn't expect this in advanced COPD. Someone whose muscles are weak wouldn't be able to take big, deep breaths in order to correct their oxygen. There was no reason for her to have a cardiomyopathy, and likewise, you couldn't correct the hypoxemia of recurrent pulmonary emboli simply by increasing your alveolar ventilation and reducing your PCO2. It wouldn't be sufficient unless, as in her case, the cause of the hypoxemia was consequent to the hypercapnia, and the hypercapnia due to a central impaired drive to ventilation that's seen in obesity hypoventilation syndrome. These patients typically have obstructive sleep apnea plus a central component. So even while awake, they have chronic hypoxemia and hypercapnia. And the other pearl that you may already know, but it's useful storing away, secondhand cigarette smoke, what we people call environmental tobacco smoke exposure. It's bad for you. It increases your risk of lung cancer, increases your risk of respiratory infections. It worsens asthma, maybe predisposes to the development of asthma in children, but it does not cause significant COPD. It is secondhand smoke exposure is not a cause of anything but most trivial airflow obstruction. Case number 3, a 75-year-old woman complaining of dyspnea and fatigue. Now, she had been fully active until 6 months ago and gradually had the progression of these symptoms, and can't identify any specific event at the beginning 6 months ago. She has no cough, no sputum production, no wheezing, no chest pain, no hemoptysis. just this dyspnea and fatigue. She smokes a little bit, 5 cigarettes a day. And on physical exam, there isn't much to find, no great clues, pretty normal. So we got a chest x-ray, likewise normal. And so we did spirometry, and that's also normal. So curious, why is he so short of breath and tired? Pulmonary function tests were done, lung volumes are normal, but here's maybe a clue. She has a reduced diffusion capacity for carbon monoxide, a reduced DLCO. We did oxygen saturation. It was normal at rest and didn't change with exercise. Did not change with exercise. So what's the most likely explanation for this low diffusion capacity? Could it be anemia, emphysema from her cigarette smoking, multiple recurrent pulmonary emboli, primary pulmonary hypertension, or maybe she has an atrial septal defect with left to right shunting? And this is a tricky one. I admit this was a true case, and we were embarrassed to find that the cause of her low DLCO, her dyspnea and fatigue, was her anemia, not lung disease. And it does give me a chance just to review with you the diffusion capacity for carbon monoxide touched upon elsewhere in this program by Dr. Chazelle, but it gives us a chance just to explore it a little further, what causes a low DLCO. I must say that on now the evidence that we have from her case history, there's not much to suggest emphysema with a normal x-ray and normal spirometry. She has no hypoxemia to suggest a recurrent pulmonary emboli. She doesn't desat with exertion, as you might expect with primary pulmonary hypertension, and the atrial septal defect with left to right shunting doesn't cause low diffusion capacity. So this case allows me to review in a little more detail what are we measuring when we perform diffusion capacity for carbon monoxide. And we're asking, how does carbon monoxide as a substitute for oxygen, which is what we're really interested in, diffuse across the alveolar capillary membrane into blood vessels and binding onto red blood cells, and is there an impairment to this process of gas transfer across the alveolar capillary membrane? And here's a beautiful scanning electron microscope image of where the gas is moving as it goes from alveolar space, here in blue on either side. Here's the wall of the alveolar wall, the interstitium. And as you can see, it's made up of an epithelial lining. Here's the blood vessel, the capillary, and so there's an endothelial layer. And here we caught a red blood cell passing through. And so we're asking, how well does carbon monoxide as a stand-in for oxygen diffuse from alveolus across epithelial and endothelial membrane into the circulation and bind to red cells, this beautiful, delicate barrier that is the alveolar capillary membrane. And we do the test, as you know, by having patients breathe in a fixed volume and concentration of carbon monoxide, hold it 15 seconds, allow the gas to transfer, and we'll measure and exhale breath, how much carbon dioxide came out. And so we'll be able to tell how much carbon monoxide was taken up by the lung, by the circulation per minute, per millimeter of partial pressure, the driving force of carbon monoxide, which is calculated. So that's what we're measuring, and often is reported also corrected for alveolar volume. That's what this VA stands for, which is a rough estimate of total lung capacity. So the diffusion capacity for corrected for alveolar volume is the same milliliters of carbon monoxide per minute for the driving pressure of carbon monoxide corrected per liter of lung volume. And the concept here I think of is what happened, for instance, to that patient who has normal lungs but had a pneumonectomy following a motor vehicle accident. So they have one lung, and it's a perfectly healthy lung, perfectly well able to transfer gas across alveolar capillary membrane. If you measured their ability to take up carbon monoxide, it would be half normal. The volume is half, the uptake of gas is 50%. But it's a healthy lung, and so you want to report it as, for this amount of lung tissue, corrected for alveolar volume as an estimate of total lung capacity. For this amount of lung tissue, the transfer of gas is normal. The diffusion capacity corrected for alveolar volume would be normal in someone with a healthy lung status post-pneumonectomy. What would cause a low diffusion capacity? And there are basically three things that I keep in my mind. One is interstitial lung disease, thickening of the alveolar capillary membrane. So this, they call it a diffusion barrier, diffusion defect, just this thickening of the wall, so it takes longer for gas to transfer across into capillaries. There could be destruction. You've lost surface area. There's just less alveolar capillary membrane surface available, as in emphysema. Or there could be obstruction, preventing the red blood cells from circulating through to pick up the carbon monoxide. And so vascular obstruction, pulmonary hypertension, recurrent pulmonary emboli would do the same, low diffusion capacity. So I can remember this: interstitial lung disease, emphysema, pulmonary vascular disease. Those are the common causes of the low diffusion capacity corrected for alveolar volume. And rarely there might be just decreased capillary blood volume. That would be a right to left, not a left to right shunt. But, and here's the point about our patient, we have to correct our report, our diffusion capacity, for the amount of hemoglobin circulating. If you're anemic, if you don't have as many red blood cells there to pick up the carbon monoxide, your diffusion capacity will be reduced. The laboratory should do this. They should measure hematocrit and correct DLCO for hemoglobin percentage. They routinely do this if the information is available, but if they didn't have a hemoglobin measurement, they couldn't do it. In our patient, having excluded all of the other causes, it turned out that it must be anemia that was causing her low DLCO, because nothing else fit, and in fact she was anemic. The other thing that can do this, mimic lung causes of a low DLCO, is a carboxyhemoglobinemia. The patient has been smoking a cigarette, put it out, and went into the PFT lab to have a measurement, because the assumption is carbon monoxide in the alveolus transferring across the alveolar capillary membrane into the blood meets no back pressure from carbon monoxide already bound to the hemoglobin. But if there is some concentration of carbon monoxide in the blood already, it will reduce the transfer of gas. And then we talked about what happens if you had a resection of lung tissue. A reduced lung volume can be corrected by measurement of DLCO, corrected for alveolar volume. Good. So this was our pearl. Anemia is a cause of a low DLCO. If the test results are not corrected for hemoglobin concentration, we need to check. Similarly, cigarette smoking immediately before testing, or other causes of carboxyhemoglobinemia can cause a low DLCO in the absence of any true cardiopulmonary disease. And I thought that test that we did, that oxygen saturation with exercise, was particularly helpful. Let's put this pulse oximeter on your finger. Let's go for a walk. Let's climb a flight of stairs. Let's see how short a breath you get. And also let's see if there's a change in oxygen saturation. And the fact that she had no oxygen desaturation with exercise made you think that this was not some interstitial lung disease, pulmonary vascular disease, or emphysema. I think that's a useful rule-out test. Oxygen saturation measured with exertion. And here is an old slide, but I think also another pearl, quite interesting in terms of the role of diffusion impairment in causing hypoxemia. I saw a patient yesterday with a low DLCO, and the question was this the cause of dyspnea? And it, as shown here, unless the diffusion capacity, they talk about 55%. Unless the diffusion capacity falls less than about 55%, then you can, with exercise, see hypoxemia. But in a mild, moderate reduction in diffusion capacity, that isn't sufficient to cause hypoxemia. DLCO has to fall less than about 55% of normal before you begin to see it as a cause of exertional hypoxemia. Let's just think, what could cause an elevated diffusion capacity? Someone might ask this on an exam. And interestingly, diffuse alveolar hemorrhage might be a cause. Here, someone inhales carbon monoxide. It is taken up not by blood in the capillaries, but by blood pooled in the alveolar spaces. And so we have excess amount of carbon monoxide taken up. It looks like the lungs are doing a terrific job, but it's not transferring into from alveolus to capillary. It's all pooling, being picked up in the sink of blood cells in the alveoli. So people have used monitoring of an elevated diffusion capacity to test for recurrent alveolar hemorrhage in patients with Goodpasture's disease, for instance. And then something that might cause increased capillary blood volume to pick up more carbon monoxide, acute pulmonary edema. We don't usually do DLCO testing, and left to right shunt would do that as well. Increased diffusion capacity. All right, we have one more case we'd like to touch upon. 23-year-old woman with shortness of breath and wheezing that has not improved with bronchodilators and inhaled corticosteroids. So she reports asthma of about 2 years duration. It's gotten worse over the last 6 months, and particularly at night, she has lots of wheezing. Her husband, who came with her to the office, said, "Yeah, I hear even loud wheezing when she's asleep." She's on a high-dose inhaled steroid, long-acting beta agonist, a leukotriene receptor antagonist. And so just recently, she was prescribed oral steroids, but even that didn't seem to bring a lot of benefit. So at home, there's wall-to-wall carpeting. She doesn't have any pets, no observed cockroaches or mice, thinking about things that are driving. That might drive poorly controlled asthma. She has seasonal allergic rhinitis, especially in late summer and early fall. She works as a librarian in an old public library building. And physical exam, she has both inspiratory and expiratory wheezing, otherwise normal. And so let's go do spirometry. Here it is. Here's the flow volume curve. Here are the numbers with the vital capacity, 80%, FEV1, 66%, and the FEV1 to FVC ratio reduced at 0.7. In a young woman like this, you'd expect on average 0.82 to be the ratio, and this is the lower limits of normal at 0.76. Okay. What's the most likely explanation for this refractory asthma? Do you think it could be her reflux, allergen exposure in the bedroom, the carpeting and dust mites, occupational exposure with continued work-related exposure, occupational asthma from this dusty library, or upper airway obstruction mimicking asthma, or uncontrolled sinusitis, rhinosinusitis? And I hope you're thinking something funny about her asthma. Maybe there's something in addition, an upper airway obstruction as you may have noticed from her flow volume curve. Here it was. Remember, the numbers look typically obstructed like asthma, but this curve has this striking flattening during exhalation and again on inhalation, source of wheezing on exhalation and inhalation, but it's flat, it's plateaued. There's one flow rate here, what is it, 3 liters per second, throughout the major portion of exhalation, and one steady flow rate on inhalation as well, suggesting an upper airway abnormality. So this is just one more review of spirometry and flow volume curves. Here's spirometry, the volume exhaled on each second of time, but the same test displayed as flow on the vertical axis, volume on the horizontal axis, and each point along the curve then of flow and volume. Here's peak flow, so it's big breath and blast. Here it goes, out, 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 peak flow quickly. Keep going, the air is coming out, it's slower, but keep going, keep going, keep going, keep going. No air to come out, and then back in. And this is the normal flow volume curve. And just to remind you, asthma, COPD, bronchiolitis, there's obstruction and a characteristic scooped, concave, ski sloped appearance to exhalation. Inhalation should be pretty much normal. And this is the pattern of diffuse intrathoracic airflow obstruction. You can't mimic this in any way. This is diffuse lung disease. Whereas hers look much more like this, evidence of an upper airway obstruction, both on exhalation and inhalation, where the air is going through a narrow orifice, and that determines the flow, and the flow is steady throughout exhalation until it drops off to back to zero, and same on inhalation. This could be inside or outside of the chest. It's fixed, it's irreversible, it's some tight stenosis or obstruction. Sometimes it's variable. Sometimes you see it on exhalation. Here you could see maybe a normal peak. Hers didn't, but on exhalation, plateaued. But on inhalation, normal. This is a variable obstruction. And because you're seeing it only on exhalation, it points to something inside the chest being exposed to pleural pressures, which make everything smaller and narrower on exhalation. So a variable intrathoracic obstruction. And if here, like the trachea, inside the chest, on exhalation, there's a narrowing. Air is coming out, you're exhaling. There's a narrowing from positive pleural pressure, but when you breathe in, everything is getting better. And so inhalation was able to pull apart this floppy variable, like a tracheomalacia, upper airway obstruction. And here's the opposite. If it's outside of the chest, central airway, but not exposed to pleural pressures, maybe larynx, on inhalation, but a normal exhalation. And here's the cartoon suggesting that on exhalation, if it's outside of the chest, you're going to be able to expand the trachea and push apart the airway walls, whereas inhalation will suck together this floppy upper airway. So what about our patient? We better get a chest x-ray. This flow volume curve looks very abnormal. Chest x-ray, you have to have an eagle eye to say, I don't know about something going. If you're looking at the trachea, maybe let's look close up. Here's the tracheal air column, black and black. Here's the aortic arch. Maybe there's something there. We better get a CAT scan. The old CAT scan, here it is. Oh my gosh, she has a tumor, young woman, tumor growing in her trachea, benign tumor, nearly obstructing the airway. Here in an early coronal reconstruction, you can see this tumor blocking the upper airway. She was referred to a thoracic surgeon who was able to resect this tumor and kid me ever after that she had cured asthma in my patient. But this was upper airway obstruction mimicking asthma. And the pearl here is that the flow volume curve is a clue to the cause of obstruction. And this plateau, this flattening appearance, suggests an upper airway obstruction. If there's scooped concave appearance on exhalation of the flow volume curve, that tells you it's intrathoracic diffuse disease like asthma, COPD, or bronchiolitis, bronchiectasis, etc. And this, I think, but just a reminder, I think it is a truism that people with asthma will respond dramatically to systemic steroids. Failure to improve despite 40 to 60 milligrams a day. I think you're thinking, what's going on here? That's very odd. Let's think about alternative diagnoses, because purely steroid-resistant asthma is quite rare. I provided some references and enjoyed discussing some pulmonary cases with you today. Thanks a lot.